we can connect to Homolka Hospital because we did already yesterday the first case, this cryoablation. So we start now. We move in this schedule, and we start with a Homolka case. Okay, Peter.
Hey.
Oh, Vivek.
Hello, guys.
Okay. Hi.
Good morning.
We are four here. Okay, Vivek, Honza Petru, Veronica, and me. Actually, we will introduce the case. Pavle, can we introduce the case?
Yes, hello everybody. Our next case from Homolka is AFib ablation of atrial fibrillation using the pulse field cell FX technology. We have here a 70-year-old woman with paroxysmal atrial fibrillation with frequent paroxysms. The arrhythmia was captured quite recently, and propafenone treatment was ineffective. Here is the EKG at admission. Her ejection fraction is normal, and her left atrium is slightly dilated and shows on the CT scan 4 nice pulmonary veins.
Okay, so, can you hear me okay? Joseph?
I can hear you. I can see you. We can hear you. We can see you.
Okay, very good. So, so again, the goal today is to isolate the pulmonary veins using the nanosecond technology from Pulse Biosciences. And I should note this does not have regulatory approval, so this is part of a clinical trial. So I think before we get started, well, I'll just ask Peter to sort of describe the catheter itself. You talked about it yesterday in his presentation.
Actually, I show you yesterday that the catheter is equipped with the 2 rings. Okay, the outer ring is like 30 millimeters, and there's a 22 inner millimeter diameter. The catheter itself got 5 spines, 5 digits with sensing electrodes, and 1 pair of sensing electrodes are in the shaft. So the catheter is very flexible. And actually, as Vivek mentioned, we are going for PV isolation first. So actually, I can show you how adaptable is the catheter. So these two rings should be in the contact because they are ablative. So actually the ablation is going in between them, full rings. There's like 360 degrees radius of ablation. So we like to have like this position in the PVs, and then we can go out of PVs for the antral. For posterior wall, we are probably not doing today, so it's as well very nicely adaptable. Can you focus on this? So you can see that all the rings, 2 rings, are in very, very good contact. And actually, we can show you even the screen, the generator, the console, which is actually controlled by operator or by technician. Okay, Vivek? Can you add something to this?
Yeah, no, I guess the only point I wanted to make was, again, just in case you didn't catch it, the 2 rings act as the 2 different poles. So there's energy being delivered between the 2. So the electrical field is this toroidal volume that's around the 2 rings. So hopefully that makes sense. Now let's come to the actual case. So far, this is what we've done. We used, and here we're using the CARDO system. And I should note, there is no integration at this point between the CARDO system and the catheter. So what we're going to do, or what we have done, is to use an octave catheter to create the shell, and then we put this catheter in. Now there is, or we will put this catheter in, and based on the electrodes, the 2 electrodes on each spline plus the 2 on the shaft, so the 12 electrodes, the system is going to render the catheter. Again, the localization is not based on magnetic, it's based on electrical impedance, so there's a little bit of inaccuracy there. Okay, so one other thing, let me just step on the fluoro for a second. Do they have fluoro? Let's make the fluoro big for 1 second, if you don't mind. I just want to show people what we have. So at this point, you can see there's the guide wire, there's a 12 French sheath that's in the left atrium. You can see a CS catheter. We also have the octave that you see here. If you leave it in the chamber, you have better electrical impedance reconstruction. Okay, now let's show the ice and fluoro, because one question there was yesterday was how to get the ice catheter in the left atrium. So I thought we'd start off with that step. So I know they can see the fluoro. Let's also show the ice image, please. That's fine. We can use this one. Okay. So what you do, if you look on the ice image, you can see here, I'm in the right atrium, obviously. Let me pull this back out of the way. And you can see where the hole is. It's right, the transeptal hole will be right there. So on fluoro, I'm going to pull the sheath back so there's just the wire. And there you can see much better. So I deflect toward it, and then, well, that was too easy. Okay. So anyway, sometimes it's a little bit harder, so you have to work at it. But that time, obviously, it was too easy. Fine. Then we do the obvious. We go ahead and advance the sheath over. Let's deflect here. And as in all big sheaths, we have to be very careful about air management. So let's take this one out. Thank you. So I'm going to aspirate. Anytime you put a catheter in or out of the sheath, you gotta flush these things. And to introduce, actually, can they see this? So here's the catheter. There's a little introducing element. We push that in the sheath. Make sure blood is coming out. Advance. Let's aspirate a little bit. Flush. And then, now the catheter is going to enter the chamber. You can see on fluoro. Hopefully you can see on fluoro. Is this high quality? It is high quality. Okay, so you can see everything there. What we'll do with the ice, let me just have this. So that's obviously the appendage, but we don't care about the appendage today. So what we're going to do is I'm going to do a backward deflection just to take it a little bit further away from where we are. So there is the left common. If I clock, that's obviously the aorta. And I clock further, undeflection, and I pull back a little bit. That's the right inferior vein right there. Clock further, that's the right superior. Okay, let's go back. So I'm going to do a little backward deflection, a little rightward. And that should open this up reasonably well. And it's not the best, but it's okay. I think that's okay.
Yep.
Okay, so there it is. So that's the catheter. Can they see it on the Cardo screen? Yeah, they can. You can see the various electrodes, nice and big. Again, the accuracy is not going to be perfect. Okay, this is based on electrical impedance, so that has its limitations, obviously. So let's do this. And the other thing you can see, by the way, when you push up against this, it inverts. That only works when the proximal two electrodes are uncovered. If I cover them, let's do that. If you cover them, then the system has no idea if it's leaning forward or backward. It has to use these two electrodes. So there, I just pull the sheath back again. There's on fluoro, you can see where I am. And then I can push toward the vein. We can actually enter, let me have this 1 second. Yeah, let me just have it 1 second. I want to see something. Yeah, okay, good. All right, good. So if I want, I can push, that's toward the appendage. Yeah, good. Okay, so let's zoom in. Stefan, show the top-down view also a little bit bigger, please. Yeah. Or they're too lopsided. Make this one screen a little smaller. Yeah. Not that much smaller. Okay. Anyway, so at this point, I hope you got a good feeling for this. We also have the CT scan, right, Stefan? So this patient happened to have a CT, so we registered that. Let's look at it on the CT. Maybe it'll be better. On the top-down view also, please. I don't know. I don't know what I prefer. Sometimes it's nice to register, and sometimes you just want to see the real deal. Okay, anyway, so the strategy that we like to use on the left side is sort of go inside the vein a little bit, deliver one lesion, pull back and deliver more osteo. This patient, let's show the baseline voltage map. I don't think we talked about that. As you heard, the clinical history is the patient has fibrillation, no flutter. If we look at the baseline voltage map, let's rotate that around, please. You can see it's overall a reasonably healthy looking atrium. There's not much disease, not much on the posterior wall, so this is not a patient I'd like to do posterior wall ablation. I'd rather just keep it to the veins. And the patient doesn't have a history of flutter, so unless we induce flutter during the procedure, we're not going to do a flutter line. But we can sort of show how the catheter will be positioned to do such a line. Okay, so let's get going. So here I'm sort of inside the vein-ish. I can look on fluoro. I'm going to show you all this just so people get the feeling. So here, it's inside. You can see that on the bottom part, it's a little bit prolapsed inside the vein. That's okay. We'll deliver one lesion here and back. If you look at the, can they see the PRAGUE screen? Yeah. If you look at the PRAGUE screen, of course, there's EKG on the top. The white in the middle represent the bipoles from the two small electrodes on each spline. So each electrogram represents a bipole from one of the 5 splines. And of course, on the bottom is the CS catheter. Okay, any questions so far? Otherwise, we'll go ahead and get started.
Doesn't seem to be the case.
Okay, then let's get started. So
So can we have shadow?
yeah, let's go ahead and shadow this thing. And then we have to
Timing?
turn off the magnet
Timer.
because I don't
Sorry.
know why. Okay, let's go ahead and ablation, please.
Timer.
Ablation? Okay. So there you see the what is it, the artifact. And
Well, we were talking just a few minutes ago about bubbles and
Yeah.
thermal effect. I
Yeah.
see a lot of bubbles here during
There are a
the
lot of
delivery.
bubbles. So, as you know, there are different reasons for bubbles to happen. One of them is superheating, right? That's a very important reason, and the main reason that certainly in the RF time, we were so concerned about bubbles and continue to be concerned about bubbles in the PF time. But the reality is there are other reasons to cause microbubbles, and one of the main reasons, especially when you're in the nanosecond range, is electrolysis. Let's do one more lesion right here, please. Oh, no,
Shadow-
actually, no, hold on,
okay.
stop. Let me get a better position. I'd rather do it here.
Anterior.
That's too anterior, yeah. No, this is actually good. I like this position. Yeah, this is good. Okay, shadow here, Stepan. So the point, though, and actually, I'll let you show the bubbles here one more time. So if you focus on the ice, okay, ablation, please. You'll see that there are bubbles right there, right? But these are really electrolysis. Remember that this is not like most of the other systems, well, all the other systems. This is in the nanosecond scale. So here, it's very high energy. I don't know if I know exactly what the actual amplitude is, but it's high. I mean, I think it's over 10,000 volts. So on the other hand, they're nanosecond duration pulses. You want to do one extra one?
Yeah,
Since it's
we'll do it,
common.
yeah.
Let's do one extra lesion here. Okay,
Yeah,
shadow and ablation.
Vivek, we had a very nice lecture of Atul
Ablation.
showing all these, or discussing all these issues, the causes for bubbles. And
Yeah.
so I just
the right side.
wanted to emphasize that you may have bubbles, but it may not be thermal effect. And he also
That's right.
explained why these nanosecond pulses are,
Here.
they need high energy, but they may not lead to thermal effect. Like the longer application, the longer pulse, the more risk of thermal effect.
Yeah. Wait, let me just put it right here. There's the inferior right there. So that's the inferior vein right now that we're right up against the ostium. And I sort of like this position. Are you ready, Stefan? Yeah, let's shadow there. Yeah, no, I mean, your points are well taken, and I think that's really important. Now, having said that, I do agree with each of these technologies. We do need to understand what is the thermal effect, and you know what, let's do this. So we put one lesion inside the right inferior. I want to now go to the right superior, right there. So I'm sort of inside the right superior here.
So
Let's
one
reset that.
lesion is enough?
Yeah, ablation. One
Shadow.
lesion at each
Shadow,
location.
shadow.
One lesion at each location is more than enough. This is a very, very efficient and
Awesome.
powerful ablation technology. Now, having said that, I am going to do additional lesions because I put one in each. Now what I want to do is sort of go in between, and I like to do a posterior carinal region right. I won't call it a carinal. I don't know what I call this, but let's do a lesion. So straight PA view, Stepan. And I'll just show you fluoro also. So this is the sort of the position that we're
You
at.
can see on
Again,
ice that there
Nice
is
contact.
okay.
covering
Okay,
this
let's
area
go
between
ahead
the
and,
veins. This would
shadow
be
there and
inferior,
ablation.
superior vein, so and a corresponding site on the
Yeah.
map.
The other thing I just want to emphasize, Joseph, is how useful it is to put the ice catheter in the left atrium. I mean, I find myself doing this now for any time I'm using a large footprint catheter, like this catheter, like Fairwave, whatever. I just find it very useful. Let me have an REO view here, please.
I think we showed that also yesterday during our case, that you have more details. You can even see the thickness of myocardium, and you can see all these details much better than from right atrium, obviously.
Yeah. Now look here. Right now I'm pushed up against the anterior wall, and not surprisingly, if you look posteriorly, which is right here, part of the spines are touching anteriorly, and then some of them are just floating in space. This is what happens. I mean, the reality is you don't get contact with everything all the time, and that's okay. Yes, there will be hemolysis, and that's the price you pay. But I was listening to the conversation about hemolysis. Actually, let's just shadow and ablate, please. And I tend to agree with the comments that, if you just do PV isolation, hemolysis is a non-issue with most of these catheters. And, when you're comparing across technologies, it's actually not fair to normalize to the number of applications. You got to normalize to the lesion set. That's actually, I think, the most appropriate way of thinking about it. How many have we done so far, lesions?
I hope so. So the superior part of.
Should we do one extra one? Let's do one extra here. Okay. Let's go ahead and ablate here, please. Shadow and ablate. So we're almost done, actually. You can see that the lesion set goes fairly quickly. What we'll do is we're going to, maybe I'll do one more. Should I do one more? This is, by the way, this is the problem. It's so easy to do PFA. The question is always, should we do one more? Look on fluoro. You see how the catheter is positioned. Now, if you look here on Cardo, it doesn't look right. And the reason is because I covered the last two electrodes. When I pull it back, then we actually see what it really looks like. Does that make sense? Yep. Okay, shadow here, last lesion.
Of course.
Ablation, please. Okay, after this, let's do
May I
the...
ask you, do you have another case? Because we did one case yesterday, this cryo.
No, we don't have now the additional case for this morning session.
Just to be sure, because we have in our lab, we have Peter with Afera, so he will show the case. So
now we have how much?
To be sure
if I could take another maybe 10 minutes, Joseph.
Yeah. Okay.
Okay. What I want to do is let's do the. I'd like to do two things. One, I'm just going to do the just do a quick left-sided map, and two, I just want to put the catheter back in on the right side and just show you the positioning for the CTI, which we're not going to do, by the way, because this patient doesn't have flutter. If that's okay.
I assume that would be basically the same like flower.
It is. It is.
On
Well,
the
if it's,
CTI.
Yeah, let's paste, please, and let's start mapping. So, what's that? Yeah, Octaray's in. Octaray seems unhappy right now. Why is that? Okay. Okay, so we're going to start mapping here. Okay. Am I taking the points? Fine, I'll take the points. Oh, no, you know what? I don't want to. Are you going to project onto this, or what's the story? What's the color field threshold?
It was 3.
I need to see the window, because I don't know what I'm looking at here. Oh, let's paste. That's the problem. Delete all these points, and let's paste, and then we'll do this. You got to paste the CS, guys. Okay, great. Let's set the window, please, and let's do a new map, Stepan. I meant new remap. Okay. Is our window good? Okay. Well, let's exclude the V, but that's fine. Okay. So now what we'll do is we're going to map here. What is our color field threshold here? It's like painful. 3 is, seems unnecessary. How about 5? No, do 5. 5 is okay. 7 is fine. Do 7. I don't care. Okay. Now, obviously, it's not colors that matter. We need to actually look at the electrogram. So hopefully you can see that this really is isolated. Because anteriorly, there's some far field stuff, as you expect. Is that green dot real?
Sorry?
No, it's not. No, it's not. You see, it's a pacing spike. It's an artifact. Okay. This, we should have just done a
How many
remap.
applications?
There's too many. How many applications did we do, by the way?
9.
So in this case, we did a total of 9 applications. I think the mean number of applications when we just do PVI is usually like around 11 or something. Stefan, let's shave here. This is horrible.
So we can also comment how fast we were, because from the beginning of first lesion to the last one took, I think, 9 minutes just. Okay, so you see how fast it was.
6 minutes.
No,
6 minutes?
no, it was 9 minutes.
Okay.
We got 9 minutes there on timer. So we're talking a lot. Okay?
Yeah, I mean, it's usually very quick. I mean, I did a lot of talking. And
Looks like very nice antral isolation
yeah.
on both
And-
sides. And there is a common trunk on the left side. Yeah.
Oh, that was garbage. Hold on. PAC there.
He was talking. Okay, so don't represent it.
Let's go REO here, Stepan. And the other thing, notice the level of isolation anteriorly on the right side, which people oftentimes ignore, is pretty good. It's sort of what we want, I would say. And of course, we don't know what we really want because there's not really good data on what actually translates to good clinical outcome, but at least anatomically it looks pretty good. The vein is really bloated posteriorly, Stepan. You got to shave that. All right, let's just come over here anteriorly. Are there any questions while we're doing this?
Do you have any questions? I think it looks very straightforward.
So just a few things about the catheter and the technology. So as I said, it does not have regulatory approval anywhere in the world. My understanding is that there's going to be a clinical trial that will start hopefully later this year. My understanding it'll be a worldwide trial. Well, I shouldn't say that. At least it's going to include the U.S. and Europe. I don't know if it's going to include other parts of the world. And my understanding is the current technology, or the technology in the trial, will be very similar to what I showed you today in terms of navigation, et cetera. But ultimately, APV, please. But ultimately, there is a magnetic sensor that's going to be placed in this catheter, and hopefully, eventually, it'll be rendered on, a magnetic navigation system.
That would
Okay.
help. To
Yes, it would
use
help a lot.
Technology, especially in some centers.
I think it would help in every center. It would definitely help in my center.
Yeah, but I mean, you can argue that you can do this ablation for paroxysmal without mapping system if
That is
you
true.
use intracardiac echo. But I agree that it's always advantageous if you have option to map.
Yeah, in fact, I have to say, Joseph, many of the initial cases, while we had a mapping system, either CARDO or NAVIX, we didn't even have this kind of a rendering. Like you saw that the mapping companies created these icons, which are, at least they look nice. And I think I wouldn't say they're accurate, but I wouldn't say they're horrible either. It's something in between. But the initial cases we actually didn't even have that. So we did the ablation largely based on fluoro and ice, as you said. The other thing I should note is this patient's right now under general anesthesia because it's a live case and all the talking and all of that. But we've actually done many of these cases just with deep sedation. So that's something that we can definitely do with this technology.
Okay, so can you show us this CTI positioning, because we will move to
Yeah.
the other lab if you don't mind.
Yep, absolutely. Give me, thank you. Give us a minute here, and actually let's put this back on the right side too. You gonna put that back in?
Yeah.
Uh-oh, I just pulled it out.
So,
Okay.
On the
Okay, ready?
ice right side.
Hold on 1 second. Only a moment. Okay, that's great.
Nice.
We have the view on eyes for
Okay,
tricuspid
let's
stenosis.
what's that? I will just push it out of the way. Okay, let's show the catheter here. Okay, so there you see on fluoro, there's the catheter itself, and wait, can you show the catheter, Stepan? Oh, you have to disconnect something. Okay, fine. Tell me when you're ready. Okay, there we go. Okay, you guys see, are they seeing it? Yeah, they are. Okay, so just like you said, Joseph, we're going to deflect the sheath and bring it.
You have to get some space here not to go into ventricles, so you have
Yep.
to go higher and bend it, and then you can rotate backwards.
Yeah,
You
this
need
is a
a
very-
sheath which can do a really big, let's say, close loop, so to speak.
Yeah. So this is, by the way, the sheath we're using right now, I didn't even talk about it. This is not the dedicated sheath. Which
Yeah,
one
I
is this
know.
one?
Yeah.
It's going to ventricles, see?
Yep,
It's
it is.
a relatively
So
big
it's-
curve
Yeah, we have to use a big
of the
curve.
sheath.
And there we'll bring it back down. And so there you can see where the position is. You see on the ice is, you can see it beautifully actually. One nice thing about the technology is because it has, let's paste the CS by the way. Because you have electrograms on this, you can actually see it very nicely. Stefan, let's reset it so that way you can see what it looks like. Okay, good. So, and show an inferior view, please. So LEO, rotate it up. Oh, that's this. Okay, rotate that up. So you can see there, notice it's earliest in 1, 2. Wait, why do you keep doing that? Let's reset it. Just so you can see, by the way, because it's electrical impedance mapping, the accuracy is not great. But just freeze it right there so I can just talk about it. It doesn't keep popping everywhere. And show me that. Yeah. Show number 15. So, and then hide the catheter because it's right in my way now. Can you hide the catheter, please? Yeah, that's good. Now, if you notice on that bottom view, the one on the left, the coronary sinus is on the right, so that's septal. And if you look at the electrograms on the mapping system, go to 200 sweep speed. If you look at the electrodes and then look at the electrograms, it's earliest obviously in 1, 2, and 3, 4. And then latest in 5, 6, 7, 8. You guys gain down the electrograms on PRAGUE. It's like way too high. Can't see anything. Get him down a little bit further, like 5, 6, and 7, 8. Yeah, okay. So anyway, the only point I was going to make is that we could use this to map. So after we ablate, we could, if we were going to ablate, we could approve that there's block, etc.
Oh.
Okay, I think that's it.
Yeah, thank you very much for a nice demonstration. I think there are no questions, or do you have any question or any comment? No?
I should say, by the way, when we have done the ablation here, next to a coronary, we typically do give give nitro. So we give a little bit of phenylephrine, nitroglycerin, wait a minute, start the ablation, and hence avoid spasm.
Okay, thank you very much, Vivek. And
Okay.
Thank you.
safe
Thanks,
trip
everyone.
home, because you are leaving today, as we discussed yesterday. So
Yeah.
thanks for coming, and see you next time.
Thank you again, and
Okay.
everyone enjoy the conference.
Thank you.
So can we move to ICAM? Peter.
Hey, good morning. I'm here alone. The initial plan was to also have Elad, but he had to leave for the airport because of the time strain. So generally, it will be just me, and what I'm going to show you is the application of Affera mapping system for what I believe is the very nice indication, and that's the post-ablation atrial tachycardias. So let me first introduce the patient. So it's a 74-year-old patient with diabetes, arterial hypertension, and he had a diagnosis of AFib 6 years ago, and that time was persistent because of this is what we did that time. We considered the best option for some of those patients. That was the surgical AF ablation using this device, which is called COBRA. So generally, it's a bipolar system that surgeon inserted around the pulmonary veins, like a big circle, creating a big box, and using the RF energy bipolar setting to isolate the posterior wall. And also, because the surgeon was there, he also clipped the left atrial appendage, so there is the atri clip, which is actually very nice because it's very kind of proximally positioned, and there is really no remnant of the appendage. I can show you that on intracardiac echo, and I believe if looking at this, I would say that it looks much better than some of these appendage occluders, catheter-based, that we actually did here. Obviously, for the arrhythmia, it didn't work that well. He had one reablation. Go back, please. And I will just mention what was happened, and did work for some time, but he got again recurrent ATs, and despite amiodarone. So now can we move to the next slide, which shows you what was done during the reablation phase of the COBRA, epicardial or surgical ablation, and generally it was to reinforce the box. So this is PA view. The white points are around pulmonary veins. And there was probably gap in the line of right inferior pulmonary vein, and there was the reinforcing the roof line and the bottom line of the box, which was completed. There was electrical inactivity or dissociated activity in the box. Nothing was inducible, and that concluded the case. Unfortunately, 4 years later, the patient again has an AT 2-to-1, so can be moved. So this is his tachycardia. I believe if you have such ablations, you cannot say much from the ECG. It doesn't look like it's something 2-to-1, quite rapid. I don't know. You would suspect probably perimitral flutter because that was not kind of it was not tackled anyhow, and this is macro reentry around the mitral annulus. So we started early this morning to create a map during AT because the patient was in atrial tachycardia. So maybe we can now switch to Afera screen, and I will just comment. So what you're looking for, or what you're very interested, is how the posterior wall looks like, because it was isolated twice. And unfortunately, as you can see, the activation of the posterior wall is still there. So what you are interested in is there one single breakthrough, or is this a re-entry, or what is this? So if you just tilt it downwards, maybe downwards. So you can see there's a certain gradient going from septum to the lateral veins on the posterior wall. And if you follow what is the earliest activation on the posterior wall, if you tilt up, you will see that there's still this right inferior, below the right inferior, that seems to be a breakthrough, like now, and just goes into the posterior wall. So that would be one culprit, definite, like a channel of slow conduction. To be honest, this was also the site that was kind of reablated during the previous catheter-based ablation using RF, obviously.
And this
but somehow
inferior vein
this
is
location
isolated,
seems
or
to
is
be
there any signal inside the vein?
And obviously the veins are then reconnected, because that's the problem. If you have on one single site, then you have kind of activity in all of four of them. And so if you can go back to the PA, and if we slowly rotate the map to the lateral mitral isthmus, so what you see on the anterior part of the veins, there is some activity, but generally I believe this is more like a far field from the endocardium. You can see that the whole left atrium is somehow like passively activated. There is no left atrial appendage, only like a stump of the previously done. So looking at this, the question is, you want to know, is this really kind of the posterior box is in the circuit or not? You could do obviously entrainment, but I don't like to do it, especially remotely from the kind of origin of the arrhythmia, because then you may actually destroy the arrhythmia. You can convert to something else. So just looking at it, this to me looks like the whole posterior wall is passive. That was our interpretation, because generally there is no, you look for the earliest left atrial activation. So if you go to AP, and just look at the earliest activation, it's strange. It's because the whole, if you forgot about the posterior wall, the earliest activation is somewhere in the low left atrium, far away from the posterior wall. So it's like a breakthrough. So my question to the audience is, what do you think it is? Should we ablate to the green spot after we re-isolate the posterior wall or not? Or should we do some more mapping? And always, if you have septal to lateral activation and you have this like what seems to be a single breakthrough in the left atrium, I believe the mapping of the right atrium is necessary. And so we did. So do you agree with this interpretation, or is it clear that the left atrial posterior wall seems to be like reactivated, but somehow distant from the earliest activation of the left atrium, like the left atrial body?
Well,
is
definitely,
it clear for the
I
audience?
would map right atrium, and with this technology, with Affera, it's really a joy to do map of both atria, because you can follow the activation between both atria.
Okay, můžeme zapnout tu pravou mapu.
It's
A
very
pustit tam zase
instructive,
no, a pustit tam
and then
propagaci.
gives you idea what is the
Můžeme zmenšit.
mechanism of the arrhythmia.
So we did the map of the right atrium, and guess what? The most unexpected, you can see the signal goes around the tricuspid valve. So what we're looking at, and a bit disappointing, having all the potential things of complex arrhythmia.
It's like
At
typical
the end is the
flutter.
counterclockwise typical atrial flutter. Obviously, the whole posterior wall is just passive. So we obviously went to the map to the right atrium. We did the entrainment. I like to do, if I do entrainment, I like to do just one to confirm. So if we go to PRAGUE or screen and review PRAGUE screen, and that's the entrainment from the cavotricuspid isthmus, which was about 30 milliseconds longer than is the cycle length. So I believe we proved that this is the pericavotricuspid or peritricuspid isthmus. So this is what we have. I believe we can now discuss the strategy. Obviously, I'm in the catheter with the left atrium, so I thought might be interesting to just, during the tachycardia, burn this entry to the right inferior, to the whole posterior wall, to see whether it will just exterminate the posterior wall, in terms of the activation, and then pull back the catheter in the right atrium and do cavotricuspid isthmus. Obviously, there are different ways or different sequence of ways, but because already I'm in the left atrium, I would start with this just to simplify things, because sometimes, because if it's too complex, sometimes it may be difficult to understand. But obviously the other way around, like to ablating the cavotricuspid, could be done, and to re-isolate the posterior wall.
Okay, I agree with this proposal, but we should not forget that there might be another tachycardia inducible, because this atrium is already ablated heavily,
it is a third procedure for the
there
patient,
might be
definitely.
perimitral flutter still inducible, I think. So
Yeah, exactly. I was getting to that. So obviously it's a third procedure for the guy. He doesn't have the appendage. Maybe I will just switch, if you can show the intracardiac echo. So just for you, the big screen, I don't know whether this is visible, but can we go big screen left, and I don't know whether you see left superior pulmonary vein, and you see where the appendage was supposed to be,
appendage and left
and there's
superior
nothing.
vein.
So it's like a small kind of excavation, but very nicely occluded, I would say. So I just scanned to it. So generally, I believe the surgeon did a reasonable job, because there's no artificial material there, and and I also show you on the X-ray the atri clip. Maybe if you can switch to X-ray, you can see the clip there. So that's definitely explanation why the appendage is there. So I mean, if they go surgery and they do like this proximal nice occlusion, it's actually looks very good. So just to have a comment, obviously it's a surgical procedure with all the risk, but if there is other indication to surgery, I believe that's a quite good result.
This case also documents that it's difficult really to send patient for a standalone procedure.
We don't do it because this was a pre-Post-ablation era. We don't obviously do it anymore. But
there is always
6 years ago, that
day.
was not much could be done for those persistent guys. Or we could do the ablation, but we knew it. There was some kind of. So can we maybe switch to the Affera screen? You see that arm just was supposed to be the kind of slow conducting channel. Or just the channel to break through to the right inferior from where it goes. And the idea here is to do a few pulses, like to connect to the double line, the line of double potentials to the septum, and then just to put the catheter on the posterior wall to see whether there will be like electrical silence, and then go for the cavatricuspid isthmus. To be honest, with the Sphere 9, to cross the septum from right to left is sometimes tricky because it's a ball, so you have to somehow make it to pull back to the sheet, somehow get the sheet to the left, and then do this, which is sometimes easier, sometimes more difficult. So can we show the PRAGUE?
This is signal on the side?
Yeah. So you can see it's quite nice. So my guess, if I apply, and definitely with the pulse field here, because it's a thin tissue, although it's 2 times ablated, but still I consider it as like thin tissue for pulse field good enough, and there might be esophageal damage if I use RF. So for this one, posterior wall, no RF. I believe that's
Even though
pretty
you
clear.
can believe that this is not a really posterior wall, so it's more septum. It could be safe to do RF. But I would like to remind you that in many cases, actually, esophagus is touching right inferior vein because it goes oblique from right to left. It's not in the middle, like people believe that esophagus is in the middle of atrium or moving a little bit aside, but it's usually oblique, and it's typically touching right inferior vein, exactly this area where he is now with the catheter. So to do RF here would be really asking for complications. Pulse field
so we did that.
should be
The
safe.
systems initially started with RF only, so we did that. But I believe it's currently, if you have a pulse field on board and these pulses are still very good, I would still go with pulse field and make a few lesions. So just to repeat for the audience, the idea, if I did do these applications, is not to terminate the tachycardia, maybe get rid of all the posterior wall, which hopefully will happen. So
you do applications and you remap for us what
so
happened
just to
on
do a
posterior
small remap
wall.
of the posterior wall that will be all silent, hopefully. That's the plan, and we will see whether the plan will be like this. So I will just do a series of applications here. Remember, with the Affera, there are 4 seconds applications, which I should keep about 4 millimeters interlesion distance, 4 millimeters. So I'll start here. This was the first application. And the signals disappear, obviously, but we will keep insisting because that's a thick part, because it was ablated already 2 times. Let me work on this.
So green tux means that there is a pulse field delivered. It will be red, that's RF with this system.
So we are on the anterior part of the right inferior pulmonary vein.
Inferior.
I'm touching the... Okay, so let's do one more here, and I will just go on the other side. There's some temperature. If you look at these pulses, there is some temperature rise. It's small. It's 1-2 degrees of Celsius, which I believe it's no risk of esophageal damage.
You can see temperature
but it's good
here
feedback
also,
actually for the system that you are in contact. So if you have a pulse without the temperature rise, that means that you are not in good contact. So you can see the contact by this. You see the ablating kind of bull eye, and during the application there's some highlights of the temperature.
I'm showing it here. Yeah.
Okay, perfect. So now I'll do the remap of the posterior wall, just to be very brief, and hopefully, and you can see that's all silent. So our assumption, this obviously is the far field, but the posterior wall itself will be silent. There was some ectopic activity. And this is also ectopic activity. I don't know whether PRAGUE. Can we record this? Červenej?
Looks like far field
červenej, ne
signal.
modrej. Můžeme teď to nahrát, teď co tam bylo, ten burst, a můžeme to ukázat. Can you see the PRAGUE review and slow down very much? So this is what you have on the posterior wall right now. I don't know whether you see it. It's a mechanically induced electrical activity that is obviously not associated. If I pull back the catheter a little bit, you will stop to have this. So it's a very irritable tissue, but it seems the veins are isolated except of the anterior part of the left veins, which is obviously the far field. Elad mentioned that yesterday, that the system picks up the far field. But still, I mean, you have to use your brain to somehow interpret these maps, but otherwise, I believe these maps are beautiful.
Where are you now with this? The same
The
in
posterior wall. This is the posterior wall, and you
Okay.
can see if I push a little bit more, you can immediately have the ectopy, which is dissociated. And if I stop to push, it will disappear. So now I'll push, and see have the ectopy. When I pull back, it goes away. So it's mechanically driven and definitely not one-to-one. So generally it worked. So now let's go for the flutter. Obviously, so we will pull back the sheet into the right atrium. We don't have to map the whole arrhythmia again, because I believe the arrhythmia, the cycle length didn't change. We didn't expect to happen that. So now we go with the flutter line, and we will use definitely RF for that. We will be using this for many years. And I believe the RF for the linear lesions is still better choice with the current settings of Affera, because with you don't have the risk of spasm of the right coronary artery. And the second thing is the pulse field sometimes is really giving you reversible lesions, even if you go with the 4 seconds applications. And with the RF, what you do is going to stick. So, I mean, if you go for linear lesions, our learning with the system, also for the lateral mitral isthmus, is endocardially, if you have a thick tissue, use the RF. Rather than pulse field. You may stack pulse field over the RF if you feel, but maybe that it's not good enough. But the RF is probably, with the current settings of Affera, probably more chances of durable lesion in the thick myocardium. There are data that the RF lesions are still bigger than the pulse field lesions.
It's interesting
Not
that we
saying the
did not
pulse field lesions
perform
are still
CTI
big,
during
but
this
I believe,
catheter
the
ablation.
RF is for linear lesions, unless it's posterior wall, would be my choice. So generally, I don't know, you see the Affera screen. I'm on the tricuspid annulus. You can see also the eyes. So now we switch to the RF anterior. And we will do a series of lesions, just how fast this is. Budeme připraveni stimulovat, jo, kdyby náhodou to skončilo. Tak jo, můžeme začít. So this will be 5-second lesions. There will be much more bubbles because it's a RF and much more heating up tissue. So the first application, as you saw, hopefully terminated tachycardia. Can we show the review screen termination with the first application on the side? Okay, so hopefully you see that. Can we go online, big live PRAGUE screen? Because now we want to see the double potentials, so we will obviously do the whole line, although we already have a double potentials there, but that will still kind of finish the line, so there will be second lesion. You see, this is 5 seconds. It's very fast. Within 1 minute, you can do and ablate the whole flutter.
Yeah, within the study, we did typically 3-5 applications per CTI to block completely with RF. So you can do it in 1-2 minutes, regardless of anatomy, which is not the case for conventional ablation catheter tip. So it's really powerful, as Peter mentioned. And you can choose, of course, you can choose pulse field, but you just increase the risk of maybe spasm.
So now we have an activation sequence. Maybe we also can add a vector, just to explain the vector on the ball, on the sphere. The vector, because there is multiple electrodes on the surface of the thing, so maybe we can pace faster.
There is a
little
small
bit just
arrow
to get
here
rid of the, but we are in the middle of the
activation
isthmus.
wave from going. So if there would be no block,
Even
and we
faster.
are pacing from here, it would be vector pointing in this direction, and now it's pointing in this direction. So even without mapping of colors, you can see the vector direction, which, because there are multiple electrodes there are 9 electrodes on this ball, so they are basically reconstructing the activation sequence, whether you are pacing or whether there is arrhythmia. So that's such a simple tool to give you immediate orientation where the impulse is traveling to.
You can also see the PRAGUE live that I'm pacing from proximal CS, and look the distance.
It's
we are
very
just ahead
broad.
of the QRS complex. So můžeme zpomalit tu pacing. So just a short remap just to verify that that's correct, and then I will go move septally, and that will be obviously early on because that's. So we want to make sure that this is going to stay blocked, but with the RF and the Afera, I'm pretty convinced that that's going to stay. So this is very brief map, but you can see the color kind of distribution shows definitely block in the covered tricuspidismus, and you saw also the signals.
Peter, we have now we have case from Tom de Potter. He wants to join this session with pre-recorded case.
I will still keep going. Just the plan. What's the plan?
The plan is that we keep. We will run this presentation, and in about 15 minutes we come back to you. You will try to re-induce or induce any arrhythmia and remap if possible, and then you tell us. Okay,
maybe
perfect.
we will induce, but definitely the plan is to check for the anterior to prevent the perimitral.
I would probably do
so that's going to be, and you will see it.
Even if you cannot induce anything, because
exactly.
it would be already.
Okay, that's what I wanted to say, and just Tom should have his presentation. I will come back to update
thank
you
very
what I've
much.
done.
Thanks. Můžeme pustit tu prezentaci? Nebo... Yeah, it's my understanding that Tom is online.
Hello, Joseph. I can hear you and see you.
I haven't seen you for ages.
Very good. So, hello, everybody in the audience. I'm very sorry I could not stay until the last day, but I'm very happy to share with you our experiences using dual energy small tip ablation catheter, an RF PFA ablation catheter, and I will show a pre-recorded video of a live case we performed for HRS actually about 1 month ago. These are disclosures for this particular presentation, and the system we will be discussing, the system that I'm presenting today, is of course in the middle you see the ablation catheter, which is actually a minimally modified STSF catheter. It is 99.9% identical to the STSF catheter that we have all used for years. Of course, changes to the generator, which allow the delivery of both RF and post-field ablation, and changes to the mapping system, to the Carto 3D mapping system that enable this approach, this workflow. Specifically for the PFA aspect in the generator, if we deliver post-field energy in this particular implementation, the PFA pulse is biphasic, delivered, of course, through the patch as a unipolar ablation sequence, so biphasic unipolar PF delivery. Everything is pretty much automated. It is quite intuitive. There is a touchscreen on the generator. You can simply toggle between PF and RF. I don't know if you can see my mouse cursor on the screen, but you see this green slider there, where you can simply choose this application needs to be PF or this application needs to be RF. And because we are using a small tip point-by-point ablation catheter, there will of course be interest in standardized workflows. You know how we all work in RF ablation using well-validated endpoints for ablation based, for example, on ablation index. This idea has also been implemented in this catheter, both for RF ablation as well as for PF ablation. So also during the PF ablation, there is an index value that will appear, and this index value, again, will correlate quite closely, as you see here on the slides, with the actual lesion depth that we deliver. So we can pretty much stick to the workflow that we have always used. Also in terms of interlesion distance, I'm not going to go in detail on the results of this study, but what was studied in animals was, of course, the impact of interlesion distance into lesion contiguity and lesion durability. And what was seen was that an interlesion distance of 6 millimeters or less is optimal to achieve transmural and durable lesion formation. So that means we can stick to the approach we have historically used with RF ablation of a 6 millimeter interlesion distance and an ablation index target of 400 on the posterior wall, 550 on the anterior wall. And so here is the live case I want to share. And this is my colleague Peter Galen in Aalst, who is performing the case, and I am in the room in San Diego performing on the panel for the case. So yesterday we showed rotation angio for via pulse field ablation. As already mentioned in our lab, we use rotation angio quite a lot for many things. Also for this approach, it is useful, of course, because if you have only the small tip catheter, if you want to make a 3D model with the small tip catheter, it takes a long time and the quality of the model is honestly not great. So you can, of course, take a dedicated mapping catheter, but we prefer to make our 3D model like this, simply integrate it in the Carto mapping system, and then we are good to go. Having said that, for the purpose of this particular case, because it is being performed in the context of a clinical study, I should probably mention that the technology I'm showing is currently still not completely CE marked. The catheter is CE marked, but one of the components in the generator is still not. So the approach you are seeing currently is not commercially available in Europe or anywhere else on the planet. We are able to do cases because we have a randomized study protocol running to assess the impact of RF versus PF ablation on the autonomous nervous system. And this allows us to do this, and part of the study design is that we have to make a 3D map with a mapping catheter to validate the endpoints. So you will see both combined. Long explanation just to explain to you what you are seeing, and what you can see is that we have already performed ablation on the left side. On the left side, you see purple dots. The purple dots indicate the PF, the post-field ablations. The red dots on the anterior side indicate the RF ablations. And in this procedure, the patient was randomized to hybrid ablation, meaning the patient receives PF on the posterior wall, RF on the anterior wall. And here you can see we have started ablating. We started the ablation, and you will see that on the screen there, you see the ablation parameters. First of all, note that there is a fixed maximum amount of applications, which is 24 applications. After 24 applications, the generator will shut off no matter what. This is again based on animal data, suggesting that there is little to no benefit in continuing an ongoing ablation beyond 24 applications. And so next to the number of applications, you can also see the index value on the parameter window on the screen. It is currently 229, 244. You see it here, the value is increasing, and so we will ablate until we reach our desired index value, at which point the tag will become dark purple, indicating that we have achieved the endpoint for successful ablation, and we can move on. You see in this application, we reached almost, but not quite, the predefined endpoint. I think the index stopped at 349 instead of 350. But I hope you can appreciate that in terms of workflow, in terms of what the operator is doing, it is extremely familiar. Of course, it is extremely familiar, and it is the workflow we have been doing for maybe 20 years. The only difference is in parts of the atrium, we can choose different energy, post-field ablation, or mainly safety reasons. That means, of course, in the posterior wall, we will no longer need to worry about potential damage to the esophagus. The issue, as with all PF technologies, has been completely eliminated, and we will be able to do our ablation in complete safety, having the comfort of knowing and being able to tell our patients that the very small but dramatic consequence of potential damage to the esophagus has been completely eliminated. So moving on a little bit in the video, here here is still a gap. The system will indicate this. Yes, so I mean, these features of the CARTO system, I'm sure you're familiar with. So in terms of workflow and standardization, the system will indicate us if we leave a gap more than 6 millimeters. So now Peter is filling that gap, making an additional lesion to make sure we have a continuous circle and to have maximal chance of first pass isolation, which we strongly believe is a good quality indicator, is a good indicator for potential durable isolation. And then moving on a little bit further in the video, you will see here we have finished more or less the posterior segment of the circle, the posterior ablation aspect. And now we will move to the first application on the anterior side. And for this, of course, left bottom of the screen, you see the generator. We will switch. There we go. We toggle the generator to RF ablation, and we can simply move on. So the next application will be RF ablation. It will be a red tag, and everything will be as we have always seen it in RF point-by-point ablation. So there we go. The ablation has started. A red tag will appear shortly. So waiting on the respiration detection. There we go. And we achieve our 550 endpoint, and we can move to the next point. Also note here, the reason we are doing our clinical study, as mentioned, is to assess the impact on the autonomous nervous system. Note that the patient's heart rate is around 70 beats per minute. You can see it right bottom of the screen. There are some PVCs and PACs, but there is a relatively stable sinus rhythm at 70 beats per minute. And what you will, of course, see, the observation that we have all made for so many years already, is that once we move here to the more antero-superior aspect of the septal PV isolation circle, we will see an acceleration of the sinus rhythm. It has already happened. The patient is now at more 78, 80, and you will see by the end of the procedure, this has increased even further. So in the interest of time, I'm going to move a little bit in this video. I'm sure you're all familiar with the concept of point-by-point RF ablation. Here, we've almost finished our circle. Note the sinus rhythm is now at 100 beats per minute. So clearly, partial vagal denervation of the sinus node in this patient as expected, because the patient is randomized to the hybrid ablation arm. And then finally, to conclude, you will see a remap. So this is the level of isolation we achieve with these procedures. Again, for the RF aspect, no surprise, but to confirm to you and to convince everybody that also the posterior ablation segment, the PFA ablation part of the procedure, has resulted in isolation at the level where the system indicates. It's a nice antral isolation, which is occurring precisely at the level where the system has put the PFA tags. I hope you can see that by doing the post-ablation mapping that we have indeed achieved this. And in this patient, as we try to document in our patients, in this patient, we have indeed achieved first pass PV isolation. There we go. That is pretty much what I wanted to show you. What I perhaps still want to share with you is the results we have presented at this year's ERA meeting, the one-year outcome of the SmartFire study, which has been accepted for publication. It will be published very shortly in Europace. Manuscript has been accepted, and we have reported a clinical efficacy, a clinical protocol derived clinical success, meaning weekly transtelephonic monitoring of 71.5% of freedom from atrial arrhythmias at 12 months. Clinical recurrence rate, meaning halters for symptoms, was 86% freedom of symptomatic recurrence. And we have also in the SmartFire study shown a clear correlation, a clear association between a standardized workflow and a better outcome. Meaning, if you stick to these parameters, and this is what point-by-point ablation allows, of course, if you stick to the predefined interlesion distance, if you stick to the predefined ablation index targets, the probability of clinical success is clearly greater than in those patients where you did not stick to those parameters. Safety profile was acceptable. There was a 3.6% serious adverse event rate. As you may know, we had a few cases of PV stenosis due to RF ablation, SmartFire study, and 0 PF energy related events. Finally, we reported an increase in quality of life and reduction in healthcare resource utilization in the SmartFire study. So thank you very much for the opportunity to present, and I'm happy to take any questions you may have at this point.
Okay, thank you, Tom, for this presentation. Any questions? There is one question.
Thanks for a presentation. What is the medium time of the procedure with the new catheter?
Excuse me, can you repeat the question?
What is a medium time or mean time of the procedure?
Yes, so the total duration of mean procedure time in the SmartFire study from memory, I think is slightly above 80 minutes. It's above 1 hour. The PF aspect in particular, as you may have noticed in the video, is currently relatively slow. RF is as you know, RF is RF. The PF aspect is per ablation point, 20 to 25 seconds with the implementation of the waveform that we currently have. This is definitely one of the, I would say, not limitations, but weaker points in the approach today, which is being addressed, which is being worked on. There is a new generation waveform, but it is not clinically available yet. This is in preclinical study phase.
That was my question, because I know that you did some remapping, I think, within the study. And as we discussed yesterday, it's very important that in many of these new technologies or new platforms, there was an improvement in pulse configuration and also efficacy of this pulse in terms of durability. So I think that's important part of testing of any pulse field technology.
Completely agree. Completely agree. And not only this ongoing evolution in design of the waveforms, but as you said, the remapping, I think 10 years ago, nobody was doing this, but I cannot imagine doing a study anymore without validating these changes with remapping data.
And if I understood correctly, this study did in all patients anteriorly RF and posteriorly pulse field?
That's correct. In the SmartFire study, although it was not specifically required by the protocol, the hybrid approach, as you saw in this live case, was used in the SmartFire study in all except one patient. There was one patient that received PF-only ablation.
Okay. Any other question? I think we discussed already yesterday with Gabor some aspects of what would be the room for this technology, for instance, for AFib ablation, or whether it opens new indications for VT or summit VT ablation. So I think people already got some understanding of this new technology. There is no question, no comment. Thank you, Tom, again for connecting to us, for coming earlier and leaving. And see you again next time. Thanks a lot.
See you soon. Thank you very much for the opportunity, and enjoy the rest of the meeting.
So we come back to Peter, to ICAM.
Okay, so welcome back. Meanwhile, we follow the plan. My plan was to rather do an empirical line because our experience is if you keep mapping every single inducible arrhythmia, you will take forever. But this is a kind of showcase, live case, so it's good to induce. So we did induce, and hopefully you can see that there was some rapid tachycardia, 202, 204 milliseconds, quite rapid. Usually it's difficult to map those. And these are like a localized re-entries, like not the macro, because 200 milliseconds is very fast. And we know with all the major are blocked except of the anterior wall and the perimitral. Even for perimitral, it's quite fast. So we did the map, and this is what maybe zoom out a little bit for the audience to have an idea of the. So generally, this is what we come. Sometimes the maps looks better, sometimes worse, because it's very rapid. Sometimes it's not very stable, but it was reasonably stable, and this is what it shows. So maybe when I look at these maps to understand them, my way is just to look at the segments. So let's analyze, for example, the anterior wall. And the anterior wall really looks like there is a kind of re-entry rotating around some central obstacle on the septum. Obviously, that's pretty easy to read. But there are also some areas of fragmentations, like low down in the mitral. Yeah, but if you follow that, you feel it's more passive and just seems to that it exterminates there. So now it was the latest part, perimitral, inferolateral, mitral. So it doesn't seem to be in a kind of way. If you look at the other segments, like mitral isthmus, keep the mitral isthmus. You see the mitral isthmus somehow it's from up and down, but there's a kind of collision of two wavefronts. So there's no continuous propagation. So this one seems passive. So just do not rush looking just one segment and say, but maybe just look at all the segments. Posterior wall obviously is out of the way, it's isolated. We didn't map the whole thing. I believe it's not necessary because it's already done. And if you just, so it looks the most kind of sequence is covered on the anterior wall. So now what we can do, I mean, my plan it would be to do an anterior line, so from where to where. And I wouldn't really go close to the appendage because that's a folded tissue, it might be quite thick, so stay a little bit away from that, maybe in the upper part of this kind of isthmus, if this is. Sometimes it terminates there, but sometimes these arrhythmias like a complex septal flutters are sometimes difficult to really get it with one point. We could use also the reversible pulse, but as was noted, the reversible pulse is a nice paper by Andreas Sarkozy that the chance that the reversible pulse will terminate depends on the size of the isthmus. So if it's a very tiny, narrow channel of slow conduction and you do the slow pulse, the reversible pulse, you terminate. But there is one, this is more wider area just going around, and the other thing is it's quite thick because it's the Bachmann bundle. So even if the reversible pulse won't do it, the normal full-scale ablation could do it. So generally, for this one, I mean, the reversible pulse, and well, if we do the anterior, we do it anyway. So I would just start to do the anterior line from here down to the mitral. If it doesn't work, I would extend more towards the right-sided vein, somewhere here. So that would be my plan to start. Any comments from the audience?
No, I think it makes sense. It changed our strategy. Instead of doing a mitral isthmus line, if you have arrhythmia, which is probably mechanism is on septum, we will change and do anterior line, which will also prevent perimitral flutter from occurrence.
Obviously, you can argue if you have a still appendage there and you delay the activation appendage, which we eventually hopefully do, we plan to do, actually, that's the aim of this line. But there's no appendage in this patient, so I believe there's no argument why not. The lateral mitral is, on the other hand, the healthy part. It's quite thick part. It's still doable with Afira, but requires the CS application and so on and so forth.
I
so
assume that you will use RF
EC.
for this.
Yeah, the plan is to use RF because my learning from the cases was for the linear lesions, the pulse field might be deceiving. I mean, especially for the thick tissue like the lateral mitral, it's for veins, I believe pulse field is great. Pulse field still gives you reasonable depth, but if you deal with Bachmann bundle or lateral mitral isthmus, to be honest, the RF is on the safer side, not acutely, you will block acutely, but also to have a durability. So
can we see the bipolar map?
Okay, so let's do the bipolar map to see how much scarring in the ventricle is. No, sorry, in the atrium is. That's a good idea. We haven't shown that, so can we switch?
Okay, sorry, I did not see you.
And if you go lateral mitral isthmus, sometimes you see that there's a lot of, maybe it's not perfectly mapped there, but it's much higher amplitude of the voltage. So the thinking is, why to go for the difficult target if you have a low voltage on the anterior wall? Because there's more chance, because there's pre-existing scarring, creates a kind of help for your transmural.
There is one question here for
lesion.
you.
Okay.
It was already answered. My question was about bipolar map there.
About?
About bipolar map, how to plan the line there.
Well, this
take
map
advantage of pre-existing
this
scarring.
uses a close unipolar signal. It was yesterday explained that there is a central electrode and you have 9 microelectrodes, so you take close unipolar signals. So it is not dependent on the activation wavefront, like bipolar and unipolar.
I will go for this anterior RF, and maybe I will not terminate with the first lesion. I want to be sure that I will anchor to the pre-existing line by the Cobra surgeon and pre-existing roof line. So I will just start here just to be sure that I don't miss anything. So yeah, that's on purpose. Echo, I'm on the ridge. That's on purpose. Again, I want to be sure that I will connect nicely to the pre-existing line. So let's go here. Okay, it was not that stable.
So you see red tags, that means RF.
Let's go here. Okay. Do you believe in Afera?
Seeing is believing.
So we obviously are not finished. No gap, no re-entry. You know who said that, so we have to keep moving. So
Hiroshi Nakagawa.
So just to explain why it's not straight line, but this kind of line that with this excavation, it's because I want to get rid of this folded tissue in the appendage, because it's probably very thick, because it's the double, because of the, I'm very close to it. So just to make me, sorry, I have to, a little bit, still you need the manipulation skills to get, the sheet is in the right atrium, I have to get into the left. Now I will do it, and I'm there very soon.
Manipulation with this catheter is quite nice. It's
quite
not very
nice,
stiff because there is no, contact force measurement or whatever. So it's like thermocool catheter. So it's very easy to manipulate, and because of this rough surface of the sphere 9, it stays usually even in slippery surface. It stays if you have some contact. So it's minimally sliding, even in ventricular myocardium. You could see it during our case on Sunday that the catheter is really, when you put it on the wall, it sticks there, and it's not really sliding too much. So that's the beauty about manipulation, or beauty of manipulation of this catheter. Is very intuitive. We have been using this catheter since 2018, so we have some experience with, because we did all studies with this catheter. Now we are using it mainly for ventricular arrhythmias or for such cases of redo, where you can map and ablate, and you can choose different energies.
And we do a quick remap just to verify this line is finished. So maybe, can you bring up the ICE image, just the full screen? And to explain why I was a little bit more, so I wanted to avoid to be too much inside this thick tissue, which is inside the former appendage. So there might be folded tissue, můžeme dát tady mapu mezi tím, that is easier to make the line more kind of anteriorly where it's thinner, which is somewhere here. You see I'm directly on aorta. There's a very little of myocardium between the aorta and my catheter. So I'm for sure being transmural. If I try to do it here in the middle of the stump of the appendage, very kind of more distally, there's a lot of tissue which is folded. So generally I try to find the easiest way to do it, not the hardest one.
Yeah,
So generally what we do now...
third dimension, because the mitral valve is anterior to
Can
this,
we give a fairer
image.
view for the audience to see how the mapping looks like so generally now I'm moving the catheter and trying to kind of do a slow, fast map. So go the anterior wall. We're doing the sinus, which is quite slow, so
it's
it takes
editing
some
itself
time.
because
It's
there
editing
is a
itself,
software
so
which takes signals from all these microelectrodes and compares always. So there is a minimal need for
So
editing.
you see that there's
usually
early
around the
activation.
annulus where
Yeah.
you can pick up a ventricular signal, but otherwise you see it's a very straightforward mapping, and you don't need to edit even, and you get immediately line of block here, as you can see here, you can appreciate.
Okay, so just finish. So I believe everybody probably agrees that the anterior line that I did is finished. The question is, should I continue more on the septum? Still some localized atrial flutter, septal flutter inducible. Probably we will try to induce, but somehow, maybe if you look at I believe this is done, this prevents perimitral, it stopped the arrhythmia. I'm pretty convinced this might be good enough. We will try induce heart, but more or less, maybe we should not do more. Because if we just keep ablating all the fragmentations in the atria, I believe it's not the point. It's not the point to kill everything. The point is to be selective and be sniper-like with the precision of the targeting the thing. So, but obviously we will still try to induce. So what we also look at the appendage activation or former appendage activation. If you go with PRAGUE online screen, můžeme dát PRAGUE online. So what you see is the activation sequence, which is index QRS. So this is in the appendage, in the former appendage. And if I go proximally to the septum, you see that it's much earlier. It's before the CS. So this is prior to the line. And if I move inside, this has to be assessed during the sinus rhythm. The pacing, you would have to pace in the former appendage or very distal CS. This is again in the former appendage. So
there is
just a
significant delay
verification.
of appendage,
Yeah.
so meaning that there is a block on the anterior line. So Peter, I will present this 360 and come back to you at let's say 15 minutes, and you can report what was the final step of this procedure.
We'll show
okay?
you another tachycardia, maybe.
Yeah, maybe. Okay, hopefully not.
Don't underestimate atria.
I do not
sustain
underestimate.
a lot of.
Everything is
surprised.
possible in
I
EP.
thought the Afera will solve everything, but you can be surprised there might be a lot of arrhythmias. So, okay, let's try to induce. Oh, sorry, ještě podíváme se na ten posterolaterální mitrální isthmus.
Můžeme pustit tu prezentaci. So I have a pre-recorded case of Afera 360 tool, which Peter yesterday showed to you, and this case will explain how it works, the whole workflow. So the technology was introduced yesterday. This is, of course, Sphere 9, but the same platform is used for 360. And instead of 9 millimeter nitinol Sphere 9 catheter, you will have the other one. This is video which was for different purpose. So here you have this 34 millimeter nitinol with an expandable size. So it's very versatile. So you can go basically from this olive to this sort of flat target. And then you have 6 bipolar electrode pairs for mapping and pacing. You have local impedance assessment to assess contact. It's 8 French, non-steerable, but it can fit into Agilis sheath. And you have, of course, electromagnetic sensors, so you can track this inside the map. You can do the map. And this was published, the first experience was published by Vivek and our team. And that was a prospective single-arm multi-center study, or 3-center study. And these patients were followed after ablation, symptomatic paroxysmal atrial fibrillation, typical population for such a study, first in man. And again, I have to re-emphasize that we did remap, and based on remap, there was adjustment of the pulse. And the third generation, Pulse 3, it was the most tuned and matured impulse. And if you compare total cohort with Pulse 3 cohort, you see that there is no difference, no significant difference in characteristics of the procedure, but there is a significant difference in durability. So 99 per vein, 96 per patient. So again, repeating basically what was done with the Farapulse initial studies and what was done with Sphere 9 initial studies. And this is important because without this remapping study, you never know what is the efficacy. So with this Pulse 3, at 1 year, we had very high efficacy. Of course, it doesn't mean that these patients will be cured forever, but it shows that there is importance of tuning this impulse. And this is now pre-recorded case from our lab, because now this technology cannot be used because there is no ongoing study, but we believe that that would be CE marked or FDA approved. So this is how you can see the tool, and it has a sort of banana shape. If you collapse, it has banana shape, which allows you to enter better pulmonary veins. This is corresponding ice image, again the same image as you saw yesterday repeatedly and today, where is appendage and vein is behind, so you know that you are entering the vein. This is appendage, this is a vein, superior vein. You see the tool here. When you pull back, you can expand to sort of mushroom configuration, and you can nicely delineate the anatomy of the vein. This is left superior, obviously. Then again, making this banana shape, and you can enter inferior vein, I believe. Yeah. And you can increase the size of this tool, see, gradually, to get shape of the antra. In the same time, you map from these electrodes which are on the surface, you map voltage, or you can map activation sequence, similar to Sphere 9. The difference is that you only can apply pulse field and not RF with this technology. This is expanded, more expanded tool in an inferior vein. This is a delivery of energy. You saw the sequence, and you see that it's in inferior vein now. This is application of energy, few microbubbles. This is a sequence You see signals here, no signals here. And again, the beauty of this link with electroanatomical mapping system, that you can display the zone of delivery. So it's not like a single point, but it's the whole zone. And it creates such a map of applications, which looks, if you have 3 of them, one is done usually inside the vein, in proximal part of the vein, then you go more proximal, then you can go even to the whole antrum, if depending on anatomy, and you mark all these applications on this map, because obviously after first application you don't see any signals, so you cannot correct. But if you see where you did apply, you can maybe identify some area which was not ablated properly. So then we will go to superior vein deliveries again. And you see this is now more inside the vein, in the proximal part of the vein, then moving outside. You have here the distance from the previous application. So you can sort of identify or predict how far you can go. Now you create bigger volume. There is no need, because it's ablating from the whole surface of the nitinol structure, so you don't need to rotate like with Farapulse, for instance. You see, this is now this kind of mushroom configuration. So now we collapse this and we can map right-sided veins, right inferior. This is right inferior vein on ice. That would be right superior vein going up. Despite the size of the device, it's relatively easy to enter even this right inferior vein. And then superior vein. I can imagine that I could do this procedure even without use of mapping, just with eyes guidance, because you don't need to see the whole atrium. You just need to see where is the antrum of pulmonary vein and in which vein you are. And you can adjust then based on the size of the vein and antrum. You can adjust the size. But obviously with the mapping system you get, and here you see X-ray. But we don't use very high frame rate. So this was done just during a clinical case, not for a demonstration. Because otherwise I would use a higher frame rate to show you more in detail, but we don't use X-ray to navigate with this tool. Not only with this tool, but with any tool. X-ray for us is just to check sometimes position of the sheath or whatever. Otherwise we navigate everything with intracardiac echo, as we discussed repeatedly during this meeting and demonstrated during this meeting. So this vein obviously is the most rounded among all veins. So the application in the right superior vein is very easy. So you can also discuss whether we need thermal energy to improve success rate of catheter ablation with pulse field, because many people believe still that you need some denervation, vagal denervation, which cannot be achieved by any pulse field technology endocardially, as we also showed in our studies. But maybe now there is a time to perform a study, for instance, with Sphere 9, where you can do in one cohort or in one arm of a randomized study can be done only with pulse field, and the other with pulse field plus anteriorly to perform RF applications. But such a study would require a lot of patients, and we have some idea that we can do study with limited number of patients, and we can do this extracardiac vagal stimulation, which you will see later on today during cardio-neuroablation cases. And we can exactly know whether we whether we did denervation of vagus or not. And then we can see what is the clinical result of this ablation. So it looks like that you have some layers depending where you apply energy. To me, it resembles armadillo armor, because they are like in sequence, like in this animal. You see? I think it's basically most of the ablation. Can we move forward on this video a little bit? Because there is not much to be seen. If you can move forward to speed up. The whole procedure was about 20 minutes, but we had to remap, so this was part of the study. So now we have remapping, and you will see that again this posterior wall is not ablated. There is a remapping after 3 months, and you see that there was a recovery of that area which was a little bit patchy. And that's a typical what we see with the pulse field technology, that it looks sometimes that there is a block, or they are touching, the circles are touching each other on posterior wall, but it recovers, and there is some stunning of the tissue only. So this patient had no arrhythmias during a follow-up, and remap showed that there is isolation of both veins, and there is no damage to posterior wall in between the circles. So that's it. Any questions to this technology? If not, we can again reconnect to the lab, and Peter will give us update what has been done in last 15 minutes. Peter?
Okay, so welcome back. There's not much to show. We were not able to induce anything else. We just remapping, looking for some late potentials and some residual potential. It's a third procedure for the guy. But there's not much, and I'm not that to do too many applications, I know, unless really necessary. There's this posterolateral region in the mitral annulus. When there is a fragmented activity, please, if you can. So you can see also the map. There's some fragmentations, but again, it's very tiny. It's close to the valve. I don't think that this can really sustain any really durable arrhythmia. So I wouldn't really ablate
On the
unless
other hand,
needed.
I think this atrium is already damaged and there is no appendage, so I would not be so much...
Yeah, but I mean, that's a very localized, very like if you do a WPW, but
so
I mean,
much
it's not like
afraid
definitely
to do any lesion in
kind
this
of,
atrium.
Yeah,
So-
but there's really, we try really hard to induce. There's nothing inducible, and maybe we can just be with this to be very selective. It was 16 lesions, Vojta said, so it's. I believe that should be our aim, like to be selective. So it was few lesions on the one lesion or three lesions for the right inferior to re-isolate the box. Then was 4 lesions for the cavo-tricuspid isthmus, and it was, I don't know, 5 lesions or 7 lesions on the anterior wall. And I believe that should be the strategy. Just if we ablate everything, maybe let's see what happens. I'm curious. I mean,
I'm not saying that you should ablate there, but I'm just saying that if you
I know,
if you
but
induce something, I would not be afraid to do any ablation in this atrium.
Most of the
as
macro
I'm
reentries
not
are
afraid
done.
in any atrium.
Should work. I mean, if this doesn't work, I don't know. So maybe it is good enough like this.
Yeah, okay. Any other suggestion? Is question or suggestion?
So I just show you the cavo-tricuspid isthmus block. I'm happy with the left atrium. Let's go back to the right atrium just to paste CS proximal, just to be sure that this is blocked. Obviously, you want to block it, but after RF, I'm pretty sure that should be. I would be really surprised if it wouldn't be not, but let me check that. So can we paste proximal?
Peter, meanwhile, can I ask you a question? Hi, Michał Forkowski. Actually, 2 questions. One is, when do you prefer to do ablations with RF and when PFA? Because we've seen in many videos that anterior lines were also done by PFA, by different operators. So if you could brief us on this, how do you decide when to use PFA and when RF? And the second question regarding the anterior mitral line and lateral mitral line, how do you decide which one to do?
Yeah, they're very good questions, and I wish I know the answers, but this is what I do. So regarding the selection of the energy, generally, pulse field looks very like a very low complication. So my idea for the veins was the PVI, and then I was excited, and so I started to do all the linear lesions with pulse field. And then I saw some reconnections. They are not common, but they are there. The pulse field is still good, but I mean, we have to talk about also dosage. It's not that the one is better than the other. We have to say Affera pulse is compared to Affera RF preset. And honestly, the RF, if you do it and you're going to block it, it's going to stay. If the pulse field, you might do it acutely, but I already unfortunately have 1 or 2 patients that had reconnections and regained the arrhythmia again. So for the linear lesions, or maybe for the thick myocardium, I try to use RF primarily because you know that you're going to, if you block, it's done. It's going to stay. That's the first answer. And regarding the anterior and lateral, that's very difficult for a mitral line. Obviously, if you have pre-existing scarring, the anterior line, even if it's longer, it's easier to do because there is a low voltage. And why should we kill the healthy myocytes in the lateral mitral isthmus? On the other hand, obviously, by doing the line, you delay the activation of appendage. Some say that may have an impaired function of the left atrium, which probably it does. And honestly, we do it nowadays quite commonly with some of the pulse field technologies. The patients are fine. The patients do not complain. They are happy because they don't have the arrhythmias. It's the easier line to do, actually. On the other hand, it can be done also with Affera, the lateral mitral isthmus line, but to do it right and the maximum chance of blocking it, you have to go into the CS, do a CS applications there, and do a RF endo. That would be the best. And sometimes still you have to stack the lesions. Yesterday showed some case that he put 14 applications on the mitral before it blocked. So yeah, the lateral mitral is still very thick sometimes and might be more difficult to do. So that's why you sometimes choose the anterior. In this case, you don't care about the activation of appendage because there's no appendage at all. But I mean, if you have young sportsman, athlete, and you don't want to do anterior line because then you impair his functional capacity. If you have elderly lady with already pre-existing scarring in the left atrium, well, I mean, they can do quite fine with the anterior line, at least clinically, and they are happy in the follow-up because they have no arrhythmias. They don't like the arrhythmias. The activation sequence of the appendage is not that much. But obviously, more is to follow on that. And now the problem was that we didn't have a kind of tool to really make a lateral mitral unless we do alcoholization of the Marshall vein, which comes with additional instrumentation. There might be some complication of that. It's well described, obviously, but it's not that easy to do. The anterior line sometimes is easier, but I leave that up to individual decision. I believe also it depends on the type of the patient. For a young patients, do not do the anterior wall.
I think this beauty of this technology is that you can choose, and you can do linear lesion. If you ask me, I would always do mitral and tricuspid isthmus with RF because it's very efficacious, and I will do also anterior line like here with RF. I would do probably other lines and posterior definitely with pulse field.
Yeah.
And RF is more durable and it's faster. We did in the study typically CTI with 3 applications, each of them 5 seconds. I did mitral isthmus line once in 12 seconds, and it was durable. So it's amazing how you can.
As they say it's not a line; it's a highway. It's an Autobahn in Germany. They call it an Autobahn.
It's a broad line. It's a 1 centimeter wide line. So, and it's in this area where you have coronary artery. Is probably safer also compared to pulse field, because with pulse field you can have spasm, you can have even it can induce ventricular fibrillation, although it's very, very rare. But I think that's the beauty of this system, that you can choose, you have freedom, and you can do this in the same time mapping. At this moment, I think it's the most versatile and universal mapping and ablation system. And there will be probably very soon more systems like this. But as far as I know, none of them has RF component. There will be pulse field, large footprint
But again, it's a Affera pulse field against Affera RF setting. It's a matter of dose. I mean, their pulse field like much higher than the Affera RF. It's not the one is better than the other. It's about the dosing, how much energy you put into the tissue. And with the current setting, still pulse field is very good. It creates a nice lesions. Still, they are there. But the RF with the Affera, probably, if you look for durability in the thick tissue, the RF is probably better. At least that's our experience. It's difficult to make a long-term data because you need a long kind of experience with patients to gather this, but that's so far our approach.
Okay, if there is no more question, I think we are perfectly in time. So we will have a coffee break now, and thanks, Peter, for this demonstration.
Yeah.